care was 4% of the gross domestic product. When my children were born, it was 8%. When my grandchildren were born, it was 16%. The Council of Economic Advisors predicts that if we do nothing, if I'm lucky enough to have great-grandchildren, it'll be 32% of GDP. That is not sustainable. And about that, there is no debate. We also know, as liberals and conservatives, Republicans and Democrats, that as a country as wealthy and as well off as we are, to have over 50 million people today who are uninsured is just unacceptable. And that access is a real function of how uninsured we are, along with a lot of other issues having to do with economics. There's no debate about that. There's no debate really about quality. We know when it comes to mortality, morbidity, and performance overall, we can do a whole lot better in our marketplace, even though we have islands of excellence all through the country. We know we can do better. And again, no argument. I would argue even on the causes, we don't have much debate today. We all agree that there is too much unnecessary care. And there is general agreement that we have to be a lot more transparent if we're going to fix what we can't see today. I would argue that the health sector is the least transparent of any sector in our economy. It's the only sector where at the time of purchase, we don't know what it's going to cost or who's going to pay. And unfortunately, we have more statistical information on every sports figure in America than we do on any provider in America. So there are a large number of issues upon which there is consensus today. The real difference basically comes down to one question. The divisive question in politics is, what is the proper role of government as we address those problems and recognize those causes? The Affordable Care Act attempted to address cost, access, and quality. And over time, we will see just how successful we are in addressing each one of the causes affecting those problems. What it didn't do is resolve the question of what is the proper role of government. Today, we have about 50% public and 50% private within this marketplace. And that will continue to evolve. So as we begin 2013, from a public policy perspective, I think there are four major levels that policy will play itself out. And I want to just touch on those briefly. Then I'd love to take your questions. The first is that we have not finished the work of the courts with regard to the tests involving the role of government, and we will clearly not have any final resolution of these issues for some time. The issue of contraception is being addressed in courts, even though today the administration helped clarify its position on contraception. The whole issue of how we control costs for the Independent Payment Advisory Board is a subject before courts. The issue involving specialty hospitals and subsidies and physician-owned hospitals, all of those questions today are still before the courts and will certainly have a very significant impact on what happens ultimately as policy is implemented. So that was the first, the courts. The second, in some ways, is by far the most relevant to what it is we're talking about with regard to implementation of the Affordable Care Act, and that's the administrative and regulatory area that Donna knows so much about. Administratively and regulatorily, I look at it as having three very important and yet specific components. The first component of this evolution of implementation of the Affordable Care Act will take place in insurance reform. We've already seen a good part of it with new patient protections, and we'll see a lot more beginning October when the new markets and exchanges will unfold. Technically, as you probably know, there are 100 markets, not 50. There's an individual market and a small group market, and both of those markets will be established either in a concerted way or independently in each state. But all of that will play itself out in a very, very visible way beginning in October. New products, actuarial value set at 60%, all the way through 90%. But that's the first component. The second component is probably the one that we'll continue to devote a good deal of time, and that is payment reform and moving away from our fee-for-service and volume-driven approach today. Can anybody give us the answer to how this is all going to play out? And as Bob said so well this morning, will capitated approaches have any more success this time than they did the last time? I'm actually confident that they will. I don't think that anyone can say with certainty how they're going to look or how they're going to be operated, but there is no doubt in my mind that payment reform will be a very central focus and feature of policy and of the practice of health as we go forward. The third and final component is delivery reform. Moving to new models, especially under the Affordable Care Act, accountable care organizations, medical homes, team-based approaches to good medicine, best practices, and the collection of real opportunities we have to improve the overall value and improve the concept of quality unlike any time in our past. The third major level will be what happens in Congress. And I see this unfolding really at also having two components. The first is the legislative approach that we've seen for the last couple of years especially. That is, amendments being offered either to improve, to change in some way, or even to repeal the Affordable Care Act. My guess is that there will not be a significant effort at success at the legislation, at the legislative side, both either through amendments or through the bills, because we really don't want to, I don't think there's much appetite to opening up the Affordable Care Act until some of this has been resolved administratively and regulatorily. Where I do see a significant amount of activity, however, is in the area of budget. Budget through entitlement reform will have a profound effect on health, especially with regard to Medicare, Medicaid, S-chip programs that we know so well. And here policymakers have one of two choices. This is so important to everybody in the room. The first choice is to do what we've done so often in the past, which is to cut and shift the program costs onto somebody else. Cut the federal level, give credit, and really look as if we've accomplished something, and do nothing more than pass those costs on to the stakeholders, to beneficiaries, and to the states. That is something I hope we can avoid doing as we go forward. There's a much better approach. I call it redesigning and improving these concepts. We already know what the causes of so much of the problem we're facing really are. And so the real question is, can we redesign and improve so as not to cost shift and really bring down the cost not only for the federal government, but market-wide? How do we do that? Well, there are a lot of efforts underway. We at the Bipartisan Policy Center in particular are looking at some very specific approaches, including a lot more transparency, more competition, shared savings, administrative simplification, team-based market models, diversifying the workforce, recognizing episode-based payments can make a big difference, dual eligible reform, wellness-based care, the role of health IT, and malpractice reform. One of the iconic businessmen of our history, Henry Ford, probably said it best. He was talking about his industry, but he could have been talking about ours. He said, coming together is progress. Staying together is a beginning. But working together, that's real success. Working together is what this conference is all about. Collaborating and working together and tearing down those silos in this new marketplace is what our future holds. I wish you well as you continue in this great and most laudable.
Affordable Care Act has authorized that are currently being evaluated, and we will take a look at just what we can learn from those projects as we go forward. But I subscribe to what others have said already this morning, that the more we can reward best practice by providing some degree of safe harbor, not only for doctors, but for all providers, I think the better and closer we will be ultimately to addressing this real serious problem. But I also share your point of view that having the opportunity to encourage everyone to work to their full authority is something that has to be embraced. It's something that has to be recognized as an important element, not only to bringing down costs, but improving quality. And I hope we can demonstrate we'll be doing a lot more of that as we go forward. I think what we have to keep in mind is that our whole incentive reward system has to be reevaluated. Are we doing the best job to reduce your costs? If your income is going down, are we doing as good a job as we can to ensure that as you are at the table to be and have the concerns you have for administrative costs, for tort reform, for all of the problems associated with providing meaningful health care delivery, are you being justly rewarded? And the question is, can we devise a payment reform system that accommodates that? And that's really what I think that the challenge will be going forward, is creating a new, more equitable, and far more appreciative payment reform mechanism that allows us to take into account the relative value and balance of the services provided. We don't do that today. Today, all we do is reward volume. And I think once we begin to recognize the importance of making that change, we're going to be able to address your challenges a lot more effectively.
Such as poverty and poor education, geography, etc., are outside of the control of the health industry. And this is an opportunity for the government to really take control here. So how does the government plan to integrate its many programs that all tackle these various issues separately to better improve health outcomes?
That's a terrific question, and I get asked frequently. So what is the new healthcare paradigm going to do with regard to prevention and wellness? And the first part of my answer is that it's not the responsibility of the healthcare marketplace solely to deal with prevention and wellness. This is a community responsibility. Donna just showed me the facilities you have downstairs here at the University of Miami with regard to health and wellness. And I don't know that I've ever seen a more impressive facility than that. My regret is that I don't see one of those in campuses all over the country. I don't see anything close to that in businesses around the country. Nor do I see the kind of effort at nutritional information and education that ought to be taking place to deal with one of the pandemics in this country, obesity. And so we have, as a nation, a responsibility, it seems to me, to incorporate what it is we're doing with health in the vast array of other dimensions that it will take to move from an illness to a wellness system in our country today. That involves schools, it involves businesses, it involves communities, it involves families, with a far greater recognition that we need to put the emphasis on the wellness side, on the prevention side, a lot more than we do today. That's slowly evolving, and I'm encouraged by what I see as I travel the country. But we're not where we need to be. And until we are, we're going to continue to face these real challenges and not deal with the kind of quality problems that we're facing with any real possibility of success.